Hello, guys. Hope you guys are doing well. Today, our topic of discussion is
Which
JVP.
stands for jugular venous pressure or pulse. P for pressure or pulse. So it is a clinical sign which is widely used bedside to look for right side hemodynamics. So my question is, where do we commonly measure JVP? It is right internal jugular vein. Then here I have two questions: why it is right and why it is internal jugular vein, not external jugular vein. Answer to this question, why right not left, is first is right IJV is more in the line of RA, more in the line of RA. And second is left IJV has tortuous course, so it can be affected by mediastinal structures. Stenal structures. Okay. So next question is, why internal jugular vein, not external jugular vein? The answer to this question is internal jugular vein is valveless. Valveless. So actually valve interfere with the pressures. So internal jugular vein is valveless. That's why we measure JVP in internal jugular vein, not in external jugular vein. And the another answer is EJV, external jugular vein, is not in the direct line with the right atrium. So this is the answer to our first two questions. Now, thus in some circumstances we can use left IJV. Left IJV. Can you enumerate some circumstances where we can use left IJV? First is if you have placed CVC in right side. First one. Second, if you have thrombus in the right IJV. If you have thrombus in right IJV. Next. My next question. How do you differentiate between internal jugular vein and carotid pulse? Point to differentiate. First is IJV is superficial. IJV is superficial and lateral. Whether this is deeper and medial. IJV is better seen than felt. Better seen. This one, carotid pulse, is better felt. Next is abdominal jugular reflex. This is or hepatojugular reflex. This means कि any abdominal compression can elevate JVP. Where this is not, where any abdominal compression has no effect on carotid pulse. Next differentiating point is any digital compression can abolish JVP, pulse or pressure, whereas there is no any effect of digital compression on carotid pulse. This. Now my next question is, we already know कि it reflects right sided heart hemodynamics. We know this. Heart hemodynamics. So my question is, can it reflect left sided heart pressure or hemodynamics? To understand this, since we already know JVP acts like a window into the right heart, through JVP you can pick information of right heart, right atrium, tricuspid valve, right ventricle and pulmonary artery. Pulmonary artery. And next is pulmonary capillary wedge pressure. So it tells you about right heart hemodynamics. We already know this. Now my next question is, can JVP tell us about the left sided heart pressure? Can JVP link to left heart pressure? To understand this, we need to understand this schematic diagram. This is the right heart, this is JVP, this is right atrium, this is tricuspid valve, this is right ventricle, this is pulmonary artery draining into the lungs. Now pulmonary veins originate from the lung and drains into the left atrium. Left atrium drains into the left ventricle. Similarly, aorta originates from the left ventricle. We know this. So कि in normal individual left ventricle in diastolic pressure is equal to left atrium pressure is equal to pulmonary vein pressure is equal to pulmonary capillary wedge pressure. We know this. For example, left ventricle in diastolic pressure increases, left atrium pressure has to increase to fill the left ventricle. Similarly, pulmonary vein pressure has to increase to fill the LA. Similarly, pulmonary capillary wedge pressure has to increase to fill the pulmonary vein. So somehow, if we can get information about pulmonary capillary wedge pressure, we can predict information of the left ventricle. So is JVP linked to pulmonary capillary wedge pressure? The answer is yes. To understand this, we again need to look at this diagram. To understand the link between JVP and pulmonary capillary wedge pressure, there are various type of anatomical barriers between them. For example, JVP, what are barriers? I need to just enumerate. This is the first barrier, JVP, jugular vein. Second is right atrium. Third is tricuspid valve. Fourth is right ventricle. Fifth is pulmonary or RVOT or pulmonary valve. Sixth is pulmonary artery. These are the barrier. If all the barriers are normal, then JVP reflects, not is equal to, reflects pulmonary capillary wedge pressure. Okay, the next question is, how do you describe JVP? First you tell the level of JVP. Example, x centimeter above angle of Lewis or right atrium. Then you comment on the waveforms. We'll discuss it in detail in coming slides. Next you comment on the respiratory variation, and fourth one is hepatojugular reflex or abdominojugular reflex. Starting with the level. First, how do you do it? You guys already know. Make the patient 45 degree, turn the face to opposite side, then measure using 2 scale or 3 scale method, measure the distance above the angle of Lewis, where you can see the maximum pulsation. And you can add plus 5 centimeter to get the JVP from right atrium. So what is normal? If you are taking reference as angle of Lewis, then it is normal is 3 centimeter. Normal is 3 centimeter. Abnormal is more than 3 centimeter. So my question is, why it is 45 degree? Why we are making patient at 45 degree angle or 30 degree angle? Because the answer is in lying position. JVP is intracranial, and in sitting position it is below clavicle. below clavicle. That's why we make the patient at 45 degree or 30 degree. Now, what are the causes of JVP elevation? What are the causes of JVP elevation? We have already discussed the barriers. Then it is very easy to enumerate the causes of JVP elevation. First is circulatory overload. Any increase in blood volume increases JVP. First is increase blood volume. Blood volume. Increase blood volume. Second is SVC obstruction. Third one is any RA pathology. RA pathology. For example, RA myxoma. Any tricuspid valve pathology. Tricuspid valve pathology like tricuspid valve regurgitation or tricuspid valve stenosis. Fifth one is any RV pathology. Any RV pathology like right ventricular hypertrophy. Sixth one is any pulmonary valve pathology. For example, pulmonary stenosis or pulmonary regurgitation. Seventh one is any pulmonary artery pathology. For example, pulmonary artery hypertension or pulmonary embolism. These are the causes of elevation. So starting with JVP waveforms. So in JVP waveforms, there are three positive waves and three negative waves. Three positive waves are A wave, C wave, and V wave. Three negative waves are X descent, X prime descent, and Y descent. We'll discuss these wave. We'll plot this wave in this graph. This is A wave. The first positive wave is A wave, which occurs due to atrial contraction. Then comes X descent. Then comes X descent. There is slight bulge in the X descent during X descent, which is positive wave, which is C wave. After C wave, there is again descent. There is again descent, which is called X prime descent. Now again there is a positive wave, which is called V wave, and there is descent after V wave, which is called Y descent. Now we will correlate these waves with the phases of systole and diastole in the cardiac cycle. Now, starting with the A wave. A wave is a presystolic wave, which occurs due to atrial contraction. Now, there is a bulge here, which is C wave, which occurs due to tricuspid valve closure, mitral valve closure. This forms the S1. So ventricle systole begins here, and the peak of V wave here, the AV valve closes, which forms S2. So A wave is a presystolic wave. X descent is also occurs in diastole. C wave due to tricuspid bulge, and X descent occur in ventricular systole. This, when the ventricle is in systole, atria is relaxing. So both X descent and X prime descent occurs due to atrial relaxation while the ventricle is in systole. Okay, ventricle is in systole, but atria is relaxing. Then comes when the blood fills the atrium, then pressure rises, which forms the positive wave, which is V wave. Then again the AV valve closes and the tricuspid valve opens. Then there is a rapid filling which forms the y descent. We will discuss each wave in detail. Now coming to the famous Wigler's diagram. This small bulge, we already discussed, this is due to tricuspid valve bulge which forms S1, and the peak of V wave is S2. Between these two, S1 and S2, the ventricle is in systole, while atrial systole occurs during A wave only. Rest of the time atria is relaxing. Now A wave already discussed. A wave is due to atrial contraction which leads to 30% of active filling. 30% of active filling of ventricle. Now the X descent. After atrial contraction, atria relaxes, which form X descent, and in between there is a tricuspid bulge because of ventricle starts to go in systole. Then the tricuspid valve closes and there is a bulge. We can understand with this diagram. When the RV starts to contract, pulmonary valve opens. Before pulmonary valve opens, tricuspid valve closes. And there is a bulge pressure into the superior vena cava which forms a small bulge which is called C wave. Okay, C wave. And again, the ventricle is in systole but the atria is relaxing, which forms X descent. Now atria is filled with blood. As the pressure rises, again a positive wave forms, which is V wave. And after this, which occurs when the tricuspid valve opens. Now starting with each wave in detail. First one is A wave. We already know कि this is due to the atrial contraction which forms 30% of ventricular filling. How ventricular filling occurs? Everyone knows 30% due to atrial contraction and 70% occurs due to passive filling, which forms Y descent. We'll discuss it later. So we already discussed this is a presystolic wave which occurs due to the atrial contraction. 30% of the ventricle filling occurs in this. What is the mechanism? Behind this A wave? This is very simple. When the atria contracts, 30% of the blood goes into the RV and a small pressure is reflected back in superior vena cava, which forms A wave. Now we'll discuss about the abnormalities of A wave. Abnormality of A wave. First is prominent A wave. Now we will discuss the abnormality of A wave. First is prominent A wave. Prominent A wave occurs because there is some obstruction to the filling of RV. What obstruction can be possible? First is A, tricuspid valve obstruction, like tricuspid stenosis or RA myxoma. Then pressure won't be transmitted into RV and all the pressure will be reflected into the superior vena cava, which forms prominent A wave. First one in this. The second cause is right ventricular hypertrophy, which can occur due to various causes. Suppose, now we have to know one point. RV is a thin wall structure which is made to accommodate volume. Now when RVH occurs, RA has to generate more force to fill the RV. So if RA generate more force, more force will be transmitted backwards into the SVC, superior vena cava, which forms a prominent A wave. What are the various causes of RVH? We'll discuss it. One is pulmonary stenosis with intact ventricular septum, pulmonary artery hypertension. Second is aortic stenosis, severe AS with septal hypertrophy, RV cardiomyopathy. Now second abnormality is cannon A wave. A wave. What is cannon A wave? It occurs when atria contracts against a closed tricuspid valve. So, what are the conditions possible? It is actually divided into two parts. Whether it is regular cannon wave and whether it is irregular. If it is regular, then it is causes are junctional rhythm or junctional tachy. In this, what happens? P wave. Suppose this is QRS. Actually, P wave merges with QRS. This is QRS, and this is P wave. When P wave merges with the QRS, that means the atria and the ventricle contract simultaneously against a closed tricuspid valve. This leads to the regular cannon wave. Regular cannon wave. The examples causes are junctional tachy या junctional rhythm or junctional tachycardia. Second is AV-NRT. In AV-NRT also similar thing happens like QRS. P wave is within the QRS or just after the QRS. This means the atria is contracting against the closed tricuspid valve. What are the causes of irregular? Example, CHB, complete heart block. There is AV dissociation. Why it is irregular? For example, this is QRS, this is P wave, this is QRS, this is again QRS, and this is P wave. Here P wave and QRS merges. This will form cannon wave. Here P wave and QRS does not merge. Then this A wave will be normal. That's why sometimes normal A wave and sometimes cannon A waves occur, which leads to the irregular cannon wave. Now next is, what are the causes of absent A wave? Absent A wave, when the atria does not contract. For example, in atrial fibrillation, or another example is due to hyperkalemia. A sine wave occurs. In this also atria do not contract. So what happens in hyperkalemia? There is actually atrial paralysis. Atria does not contract, so it doesn't form any A wave. Now coming to the next wave, which is next negative wave, X descent. We'll trace the JVP graph. This is the A, which is due to the atrial contraction. This is X descent. This is C wave. This is X descent, and this is positive wave, V wave. For practical purpose, we considered X descent and X prime descent as X descent only. This is X descent and this is X prime descent. This is C wave, which is due to the tricuspid valve bulge. So what happens is atria contraction is done, which leads to 30% of the ventricular filling. Descent occur due to atrial relaxation while ventricle is in systole. Ventricle is in systole while atria is relaxing. So the tricuspid, here in this condition, the tricuspid valve is closed. Atria is relaxing. Blood is filling into the atria, and ventricle is in systole. Now, when the atria tricuspid valve is closed, RV is contracting, and the atria is filling. When enough blood filled into the atria, the pressure rises, which forms V wave, which forms a positive V wave. Now we'll discuss the abnormality of. We have two causes for the prominent X descent. First is constrictive pericarditis. Second is cardiac tamponade. I will take another video for the cardiac tamponade. In that video, I will explain in detail why the JVP, why there is prominent X descent in cardiac tamponade and constrictive pericarditis. Now, second is causes of X descent. Causes of X descent. Causes are tricuspid regurgitation or atrial fibrillation. Why tricuspid regurgitation? Again, the same diagram. RA, RV, RV. So since we know that RV is in systole, X descent occur when the RV is in systole. So when tricuspid regurgitation occur, the blood flows from the RV into the RA, which leads to the blunted X descent. And in atrial fibrillation, when there is no A wave, there won't be any X descent. That's why tricuspid regurgitation and atrial fibrillation and RV failure. The one next positive wave, which is V wave. This is also called the volume wave. When the ventricle is in systole, atria is filling. The enough blood fills, then the pressure rises, which leads to the V wave. We already know this. Now we will look for the causes of prominent V wave. The causes are same as that of prominent X descent. For example, when there is high vena cava pressure, which occurs in volume overload condition like RV failure or constrictive pericarditis. Or second causes same, tricuspid regurgitation. Why tricuspid regurgitation? This is RA, this is RV. When RV is in systole, so in tricuspid regurgitation, RV regurgitation occur and RV transmit pressure to the RA, which leads to the more prominent V wave. What are the causes of diminished V wave? This is hypovolemia, yeah, use of venodilators. Now coming to the next wave, which is negative wave X descent, Y descent. Again, we will plot a graph. This is due to atrial contraction, A wave. This is X descent. This is C wave. This is X prime descent, which is due to atrial relaxation. Atria is relaxing and ventricle is in systole. Next wave is V wave, which is positive wave. Atria is relaxing, ventricle is in systole. This is the point where S2 occurs. This is the point where S1 occurs. The phases between these two is called ventricular systole, while after A wave, atria is relaxing. Now, after V wave, here what happens? Aortic valve closes and tricuspid valve opens. So there is, this is RA, this is RV, When tricuspid valve opens, there is passive filling of blood, which accounts for almost 70% of the blood, which forms Y descent, which forms y descent. Again, after y descent, what will happen? Again, the rest 30% of the blood is contributed by the atrial contraction. Again, it will form a wave. Again, the cycle will continue. The causes of prominent y descent, when there is high vena cava pressure. If for example, if the atria fills more, then it will empty more. Same causes: constrictive pericarditis, RV failure, tricuspid regurgitation. Same causes. Like when the atria has more blood, it will empty more. So it will empty more. So the prominent Y descent, the causes are constrictive pericarditis, RV failure, or tricuspid regurgitation. When there is slow Y descent, this is important. When there is slow Y descent. For example, Y descent occur due to passive filling. There is no atrial contraction happening here. When there is stenotic lesion like tricuspid stenosis, blood will slowly fill into the ventricle, there, which leads to the slow Y descent. Now, when there is absent Y descent is absent. When there is absent Y descent occurs in cardiac tamponade. We'll discuss this in detail in cardiac tamponade video. Okay, so now we have already completed the level of waveforms, level of JVP. First one. Second is waveforms. We have already completed these two topics. Now coming to the third one, which is respiratory variation of the JVP. Normally what happens when the patient inspires, there is filling of RA and RV. So normally the JVP decreases. Now we have one sign related to this. This is called Kussmaul sign. There is paradoxical rise of JVP when the patient inspires, when the patient takes deep breath. What are the causes of Kussmaul sign? This is constrictive pericarditis, RVMI, tricuspid stenosis, or restrictive cardiomyopathy. We have discussed these, and we will discuss this in upcoming videos on these specific topics. Now, after discussing the respiratory variation, we have another one, which is hepatojugular reflex. How do we do it? We press the abdomen. We apply a pressure for 10 to 15 seconds in the abdomen while the patient is in supine position at 45 degrees. How we define it? How do we define it? Abnormal. This is when you apply a pressure, there is rise of 3 centimeter. There is rise of JVP of 3 centimeter. 3 centimeter rise or a sustained rise of 15 seconds. Normally, when you press the abdomen, JVP rises slightly for some time, but it does not rise for more than 15 seconds. If it is rising for more than 15 seconds, then it is abnormal. Hepatojugular reflexes. Some specific condition. Now we will discuss some specific condition. Constrictive, how JVP waveform looks in a specific condition. First is constrictive pericarditis. In this, JVP is elevated. There is sharp X and sharp Y descent, but the sharp Y descent is more prominent. Both X descent and Y descent is prominent, but Y descent is more prominent than X1, and A wave is equal to V wave, and the Kussmaul sign is present. In constrictive pericarditis. Second topic is cardiac tamponade. JVP is elevated. We already discussed. X descent is sharp, and Y descent is absent. There is no Kussmaul sign. You can remember this with a mnemonic: pay tax. In constrictive pericarditis, there is Y descent is prominent. Actually, both X and Y descent is prominent, but Y is more prominent. In tamponade, X descent is prominent, while Y descent is absent. Pay tax is the mnemonic. cardiac tamponade. Now coming to the tricuspid regurgitation. In tricuspid regurgitation, we already discussed the mechanism. There is obliteration of the X descent because of regurgitant flow from the RV to RA. So there is blunted X descent. Blunted X descent. So after atrial contraction, the next wave is V wave. There is no Y descent because of regurgitant wave. There is prominent V wave and X descent. X descent is obliterated first. Second is there is prominent V wave, and we call it famous CV wave. And the next wave, next negative wave is Y wave, which is also prominent in tricuspid regurgitation. You have to remember this finding. Now the last finding, lesion is tricuspid stenosis. In stenotic lesion, there is prolonged passive filling which leads to the prolonged Y descent. So here we complete our topic, which is JVP. Thank you.